Welcome to Los Angeles. Good to have you all here. And I have 7 minutes to do this talk. No, actually, I have a little longer. We'll be fine. We'll be fine. We'll be fine. This next talk, the first one I'm going to do is about drug screening. It's a little bit of a pet peeve of mine, the notion that drug screening is a good idea. Just to step back for a second, I got to tell you that I'm a big believer, some of you know this, I'm a big believer that we do altogether too many tests in medicine and that we get slavishly reliant on tests without recognizing that they're really not, they don't help us most of the time. And there are tests that are really important and we should know what those are and when to do them. But a lot of the tests we do are crazy. And sometimes we make the excuse that it's not like I wanted to do it, it's that the next guy is going to demand it. And sometimes that's true. Sometimes the next guy does demand it. But that doesn't mean that we should stop thinking or just sort of roll over and do whatever they want. Drug screening is a great example of that. We often do it because we think it's a good idea, or many of us do, even though I think I'm going to be able to show you that it's not often a good idea. And then on the other hand, we sometimes do it because the psychiatrist wants it, or the trauma surgeon wants it, or whatever. And this chapter has a little bit of information to say that's also really, really silly. And so we're going to go through that. This course, what makes this course different than many CE courses, continuing education courses, is that we rely on the medical literature. Now, let's not get fooled. I don't believe that just because something's written means it's right. Okay, so just because it's in the literature doesn't mean it's right. We spend a lot of time critiquing the literature as well. But in general, we're going to try to back up the things we tell you over the next couple of days based on what's in there. That being said, I got to say this lecture is a little bit different because for the most part, there isn't that much out there in the literature. And because the most important things are conceptual. So we're going to spend the first 15 minutes talking about why, conceptually, this doesn't make a lot of sense, even though we think, oh, great, I'll get a drug screen, I'll know what the answer is. You don't know what the answer is, and it doesn't make sense. And then we'll spend the last few minutes going over the evidence that does exist, which says, oh, you're right. Okay, but the evidence isn't really strong, and the theory, the thinking about it, in this case, I think is really useful. So let's all do this together. Why do you do a drug screen in the first place? Why don't we just ask the patient? They don't tell us the truth, okay? Is that true that they don't tell us? Yes, they don't tell us the truth. So why don't they tell us the truth? Sometimes they're confused, right? They're altered. They can't tell us. Why else? What? They're embarrassed, right? They don't want to tell us that they took an overdose. Why else? They think we're the police. It's not just embarrassed, they're afraid of us, right? They can't tell us. What else? They think it'll affect how we treat them, which might be even true. And what else? Well, there are probably a few more, but one is that sometimes they don't even know. They thought they were smoking dope. They didn't know it was PCP. It was really true. Lots of times, what's in what they took is different than what they thought they took. But that's not just true of people using street drugs. It's also true in general that even the old person who's a big source of toxic presentations often doesn't know what they have, and it's often confounded by all sorts of other things like their comorbidities. So we can't really rely on the history. That's very different than all our other patients, right? Of course not. So let's remember right at the start that history, which is the most important thing we do, isn't perfect anywhere. And it's certainly not perfect here, but that doesn't mean we should ignore the history. The history still is probably the best thing we got. Most of the time, you'll really get a good idea of what it was by asking them. But, of course, we take it with a grain of salt and a little bit of skepticism. So we need to do other things. What else can we do in the possible overdose? Patient's altered, or you're thinking it's an overdose for some reason. What else could we do besides the history? We could do a physical exam. How good is that in general in our life? You know, when I was a student, I was on the cardiology service. I spent 4 years being their boy and running around with them and doing all this stuff. And I got to really good at listening with my stethoscope and for murmurs and all this stuff. And I thought it was really important. And then I lost my stethoscope when I came to the emergency department. And I haven't looked for it since, you know. It's not that important, right? How often is it? It's important for the show. That's about it, right? You're a really good doctor. You listened really carefully. But it doesn't really tell us very much very often. Our physical exam is notoriously poor. We'll get back to physical exam a little bit later, because in this case, it is one of the things that we should do, but in a very limited way. We don't really have time in this lecture to talk about that, but we'll just sort of mention a little bit. So what else could we do besides history and physical? Well, we could do a drug screen, right? That's why we do it. It's because we don't believe the history is really going to give us the answer. It's going to fill in for what the history missed, right? That's the whole purpose of a drug screen. So how good is a drug screen? That's what we're going to talk about. So anytime you're talking about a diagnostic test and you want to know how good it is, there are two things you got to ask about in terms of good. One is accuracy. What's accuracy? Does it tell the truth? If you knew exactly what it was, you did the test, would it find it? That's called accuracy. For most things in medicine, for anything, that requires a gold standard, right? How do we know what the truth is? With a drug screen, you can make the gold standard. We took chemical X and we tested it, and we saw how good it was. That's pretty good gold standard. I know what this is. I'm testing it. For many things in medicine, the gold standard isn't very good, and everything we compare it to then gets a little bit screwed up. But in this case, okay, we can do a gold standard. We can see how accurate the tests are. But there's another thing besides accuracy that's an important characteristic of tests that you also have to know about, and that's called reliability. What's reliability? Anybody know? Exactly. It's if you do the test over and over again, do you get the same result? And there are many things that can threaten reliability, like who's the observer? For many things, it depends upon how good you are at reading the test. So, for example, if you take a chest x-ray in a 2-year-old with a fever and you show it to 5 radiologists, how many different opinions do you get? 6, 8, something like that. So there's a lot of, so that's one thing, but sometimes you show it to the same guy 3 times. Let's not just make fun of the radiologist. How about you? You look at the same thing 3 different times, you'll see it differently. That's where there's interpretation involved. But there's a lot of other things, a lot of tests that we think are, quote, objective, there is interpretation involved. So the first set of articles I want to tell you about were done before we even had the abstracts. We started the abstracts in 77, so these are old articles, but they're really, really important. It's a great study. All the references are in there in the first part of this talk. You don't have to look at it now, but you can go back if you want and look at it later. This was done by the CDC. It was first done in the 60s. Some of you will remember, some of you are my age, some of you will remember that way back when the federal government had this program for drug addicts in Lexington, Kentucky. They set up this place where drug addicts could be sent, the ones who were shooting up, because there only were 4 of them. It wasn't half of the population. It was a very small group, we thought. And we were going to get them rehab in Lexington, Kentucky. And they built this whole program there, and they also built, to go along with the program, these federal tox labs, which were supposed to become specialists in looking for drugs of abuse. So in the 60s, the CDC took a bunch of known samples, and they sent them to these tox labs, these federal labs. This was the cream of the cream. 8 of them were just made to do this job, and 2 were UC San Francisco Hospital and the Brigham and Women's Hospital. At the time was Peter Brent Brigham Hospital. Fancy, fancy places. They sent them a whole bunch of samples. They sent them a note, and they said, we know what this is. Tell us what it is. And they did it in 2 ways. One was qualitative, and the other was quantitative. Tell us what it is. Tell us how much. Okay? And that's what we do in tox screens, right? We can either do a qualitative or a quantitative. We'll get back to that in a minute. So how well did the 10 labs do? They sent them a whole bunch of samples. How well do you think they did? They did great. More than 95%. When they were giving the blood level, they got it just about right. Very small margin of variation. They were terrific. That's not why it's such a good study. Why it's such a good study is the next part. They then did part 2, which was really the fascinating part. Instead of sending them a letter saying, here's a bunch of samples, tell us what it is, they sent them another letter which said, sometime in the next 6 months, we're going to send you more samples. Only this time, we're not going to label them. They're just going to arrive, and they'll be part of the thousands of samples you've been doing every day. And they did that. And what were the results the second time? just about 50% accurate. Almost the same as flipping a coin. The blood levels that they got, tenfold less and up to tenfold more than the actual amount. Imagine an aspirin level of 3, 30, and 300 on the same sample. These were the best labs. None of the labs did any better than any of the other labs. They repeated this study, the same set of studies, in the 80s. Very little has changed about tox labs. There is a little bit of technological change, but there's almost none. And even that which has changed still relies on, did the person who was reading it pay attention and really care? So how good is your lab when you send them a sample? So one thing right to say at the start is, be very afraid. Your lab, when you send them a sample, are they paying attention? The CDC is watching. They want to know what this sample is. I better do the job exactly right? I doubt it. Do you know how good your lab is? No, I don't know how good my lab is, but I bet it isn't all that good, because in regular daily business, these fancy labs were terrible. That's the first thing to say. That's sort of reliability. In daily work, how good are they? The second is accuracy. So let's talk about the two types of tox lab screens. One is qualitative. Is it there? Okay? That's the only one you can do a screen on. You can't do a quantitative screen. It's much too expensive and time-consuming. Quantitative, you can just say, tell me how much lithium is there. You can't do a screen. Okay, so for the tox screen that's qualitative, which is what we do on urine, right? That's the only one that's important, is urine. They do it in gastric lavage. It doesn't add anything, okay? In the ones that are qualitative, what's the problems with that besides reliability? Doesn't tell you how long. So why is that important? Maybe it's gone. Maybe it's not yet in the urine. There are a lot of drugs where that's true. Early on, you don't find it. After a little bit, you don't find it. You have to get it just right. What else? It doesn't tell you how much. There is salicylate there. Does that mean they have an aspirin overdose? And even if you have one, does that mean there isn't something else going on at the same time? You only have to worry about aspirin? And it's not very accurate. There are 20 different benzodiazepines made in the United States. Most tox labs can identify 7 of them. If you got one of the other 13, you can't find it. What's the most dangerous street opiate besides contaminant? Methadone's pretty bad. What else? Fentanyl. Fentanyl's really, really, really strong. None of your labs test for fentanyl. When you get a negative opiate, it does not mean negative fentanyl. There are a half dozen labs in the United States that test for fentanyl. So there are, and then, is the toxin the drug? Is it the metabolite? And then there are some things which they're notoriously bad at finding. They just can't find, like PCP. They are tremendously haphazard. And then there are lots and lots of false positives. When they find amphetamines, it could be just an over-the-counter nose pill. There are lots of false positives and lots of false negatives. And then, does it answer the clinical question you want to know? So if you think about qualitative labs, they're really, really, really not of much use. If you think about quantitative labs, they might matter. I want to know, I think this is an aspirin overdose. I want to see how much it is, because the amount correlates with what I have to do. Or does it? What about quantitative labs? What's wrong with that? What are the threats to using a quantitative lab? It's the best. It's the only thing that actually helps you. But it doesn't help you nearly as much as you think. Why? It could be too early. It's not yet absorbed. Okay, what else? What? Chronic overdoses. If they took more than one ingestion, the same amount of drug, the same level, is very different than if they took just one. And if they've been taking it chronically and now overdosed, which is far, far worse, they're going to die at levels where they wouldn't even notice it if it was just one overdose. That's true of lithium, it's true of aspirin, it's true of theophylline. Acute on chronic is the worst. Very low levels matter a lot. Why else? It depends if it's the metabolite. When you've been told, every one of you learns that you want to do a not only an anion gap, but an osmolar gap for ethylene glycol and methanol, right? Remember that? Turns out it's wrong. People scratch their heads. They wondered, why is it wrong? You know why it's wrong? Because the thing that kills you is the metabolite. The thing that causes the osmolar gap is the parent drug. So when the methanol's around, you got a big osmolar gap. By the time it gets metabolized into formic acid, there is no osmolar gap, and you're going to die. That's when you have the anion gap. That's when you're acidemic. Same is true for ethylene glycol. So it's a great concept. It's just wrong because it doesn't separate out the parent drug and the toxic metabolite. There's lots of other reasons, too, because it's not only the timing of the overdose that matters in terms of is it chronic or not, but comorbidity matters. So if you have poor renal function, you're much worse at a low level. If you have good renal function, you can tolerate a much higher level. Same with hepatic function and cardiac function. There's millions of things that do it. And then most of the drugs that we're worried about in overdoses have what's called a large volume of distribution, which means they don't sit in the blood. They sit in the tissues, which is why for tricyclics, the leading overdose killer for 15 years, up until about 10 years ago, for tricyclics, the blood level bears absolutely no relationship to outcome. It's just like saying, I'm going to measure the magnesium level and find out what your magnesium is. It bears no relation because it's not in the blood. And that's not just true for tricyclics. It's true for most bad drugs. They have a large volume of distribution. The blood level doesn't matter. Now, let's talk about the one drug which we all believe is important to get a level on, which we do all the time. What drug is that? Acetaminophen. There are a few articles on acetaminophen. We'll get back to them in a minute. But acetaminophen, we rely on the Rumac nomogram, right? How good is the Rumac nomogram? First of all, why do we rely on it? Why do we use it? It predicts hepatic necrosis. How well does it predict hepatic necrosis? Terribly. In the days before there was N-acetylcysteine, if you were above the toxic line, you had a 3% chance of getting hepatic necrosis. 3%. 97% of the time, you did not. No treatment, you didn't get hepatic necrosis. What is hepatic necrosis, by the way? It just means your SpO2 goes up to 1,000. If it goes up to 1,000 and you have hepatic necrosis, what happens to you? 97% of those patients do fine. 3% die. If you don't die, what kind of chronic liver disease do you get after fulminant hepatic necrosis? Sounds pretty bad to me. There is no chronic liver disease. So 97% of those with a toxic level are fine, and 97% of the little ones who got sick are fine. This is the best we can do. Why is it so bad? Why do you think it's so bad? How do you interpret a Rumac level? Based on the time. It doesn't work if they took more than one overdose. If they took 5 Tylenol, 5 Tylenol, 5 Tylenol, 20 Tylenol, it doesn't work. It only works if it was only one overdose, so that's bad. It doesn't work if it's an extended release capsule. That's bad. It doesn't work, or it's tremendously affected by what their previous liver disease was. It's protected if they took alcohol with it, so the level doesn't work very well. And most important, you can only interpret it based on knowing exactly when they took the overdose. Wait a second, I thought the whole reason we're doing this is because we can't trust the history. And this is much more precise history than, what did you take, sir? Now we have to know exactly when they took it, or you cannot interpret it. It's no surprise it doesn't work. The reason we use it is because we have nothing else to use. Because when you take aspirin, and you're sick, you look like you're an aspirin overdose. You have a toxidrome. It's not a perfect tool, but they're breathing really fast. They're not hearing me very well because they just pulled the thing out of their ear. They're not hearing well. They're breathing fast. They've got a fever. They got pulmonary edema. That might be aspirin. They're acidemic and have a respiratory alkalosis. I better think about aspirin. Ooh, they're jittery and ataxic and really wired. That might be lithium. I better look for lithium. all the things, not all, but almost all the things that are important, which require treatment, which are intoxications, we can get an idea of just by looking at the patient, by doing a toxidrome exam. What's the toxidrome for acetaminophen? Nothing. Until they're already sick. 2 days later, there's a toxidrome. Not any good then. So that's why we do the Rumac thing. Not because it's any good, it's lousy, but because we have nothing else we can go on. But realize that it's a sort of it's circular reasoning. You can't use this without the history. And the only reason we're doing it is because we don't believe the history. That's a little bit crazy. So that's what's important about this talk. Now let's talk about all the articles in here. The first bunch of articles said, we looked at all the overdoses, all the tox screens we got. And how did they help us? And basically they all say, most of the time they were either negative, we already knew it, or we ignored the results. 1% of the time we did something in response to the tox screen. We don't know if that was better, worse, or indifferent. Every one of these articles says the same thing. We did millions of tox screens. They cost us billions of dollars, and it almost never affected us, and we have no idea, the few times when it did affect us, whether it was useful. You can go through them each individually. That's what they say. This is all comers. Anybody I did a tox screen on. The next series of articles are, well, what about in psych? Okay? And that is numbers, the next one's in trauma. It's from 12 on, and there's a whole bunch in psych, which you'll have to look for because I can't. Oh, med clearance. This is starting with abstract number 16, and they all say the same thing. They all say the same thing. A couple of them say, wait, it's even worse. Because what about getting tests without the patient's permission, without informed consent? What do you do with the result? What if the patient loses his insurance because you identified a drug in there? Can he sue you? Yes, he might be able to. Next one says, you know what? About half the states in the United States have a law that if a trauma patient is intoxicated at the time of trauma, the insurance company doesn't have to pay. So there's one article in here which asked a whole bunch of surgeons, number 12, asked a whole bunch of surgeons, do you know about this law? They said, no, what do you think of it? Oh, it's a really bad law because tox screens are so important to me, but now I guess I can't do them. Then they asked a bunch of legislators, what do you think about the law? The legislators all said, really bad idea. They said, do you have a law, such a law? I said, I don't know. And of course, all the legislators they chose were in states where there was such a law. There are ethical issues about if you're going to identify intoxication, don't you have some obligation to have a program to fix it, to do something for these people? These are all things that, you just get a tox screen, we haven't really addressed. And then finally, the last set of articles are about acetaminophen. And they basically say that almost never does the Rumac nomogram actually identify somebody who both has acetaminophen at an overdose level where you would do something about it that you didn't already know. But in this case, almost is probably good enough that you should still do it. Why? Because the test is costs almost nothing. And the cost of one patient out of 500, which is the best estimate of how often you pick it up, the cost of that one patient out of 500 requiring a liver transplant is really, really high. Which is also why we set the bar at potentially toxic very low. Almost nobody is toxic. But we still treat them because the treatment is tremendously safe, easy, just really tastes bad. But other than that, it's sort of easy, so why not do it? And so I think it is reasonable to continue to do an acetaminophen level, not on everybody, not on the person who shot up heroin, but the person who went to the medicine counter and took some pills, the person who's depressed, the person where you think there's suicidality, yeah, you should get it, because half the time they don't know they took acetaminophen. It was part of the other pill that they did take. They don't know that. So I think it's reasonable to do that, but realize it almost never is going to help you. It's also reasonable to get a lithium level when you think it's lithium, or a theophylline level when you think it's theophylline. But almost nothing else about a tox screen makes any sense. It is only going to give you bad information and irrelevant information. If you can think of a reason why in this patient it's really going to help you, by all means go ahead and do it. That is almost never true of a qualitative screen, and it's rarely true of a quantitative test looking for, I think it's this.
What are your thoughts about blood alcohol levels?
I personally don't understand why we would want to get a blood alcohol level. If the blood alcohol level is high, doesn't mean they didn't have a hematoma in their head. In fact, who gets hematomas in subdurals in trauma? People with high alcohol levels. If it's high, I still got to make a clinical decision. Am I worried about it? If it's low, I'll really worry. If it's not high, well, I really worried anyway. Not to mention, it could be really low because it wasn't alcohol. They took it with something else they took. So it doesn't help me make any decision. It's only useful for, it's not Final Four season, so you have no other pools going on in the department. You can do a pool. But otherwise, and how much what's the highest alcohol level you've seen in somebody who walked and talked? 800 I saw one. Depending upon how good training you're in, how well you've trained your liver, people have enormously variable responses to alcohol. You're a novice, your level is 50, you're lying flat on your back. You're good at it, you can have it doesn't tell you. Great point. I didn't even mention that. That's true in emergency medicine in general. Rick said this is stealing from the rich to give to the poor. It's not so much the rich. It's sort of cost shifting all the time. The only person who gets none of these costs are intended to be real, right? They're to shift dollars around. The only person who gets the actual bill is somebody who's poor. If you're poor, working poor, and you say, "Look, I can't afford to have bad credit. I have to pay my bill," you are murdered by our outrageous bills. All of them. Not to mention, how much does it cost for a set of lights? Routine labs in your department. In my department, it's $40 for a Chem 7 in the laboratory. In the emergency department, it's $80 for each one. Of the 7, $560. Every one is charged individually because stat tests are charged individually. And even if I didn't want all 7, I only wanted... Which one do you want, Rick? I wanted the sodium, because sometimes that's useful. Yeah, exactly.